Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everyone, to the participants and all the guests to the conference of the teaching universities. Thank you to the organizing committee for inviting me to share my thoughts on this very exciting topic on big data and precision medicine, leveraging opportunities. Well, I'll start with these top headlines in health IT analytics for the year 2020. Well, if you look at the top 10 stories that appeared in relation to health analytics, COVID-19 and big data dominated these headlines. The top of the list is the dashboard developed by Johns Hopkins University to track COVID-19 pandemic. And of course, other platforms to look at bed capacity during pandemic, understanding the COVID-19 pandemic as a big data analytic issue, and how artificial intelligence predicts severe disease in COVID-19 patients, and how artificial intelligence determines high-risk COVID-19 patients. The rest of those top 10 stories are all related to using big data and also artificial intelligence to manage or to improve the management of COVID-19 during the pandemic. So this is what Johns Hopkins has produced for us, for the global researchers and those who want to see what's happening in the COVID-19 throughout the world. This is the dashboard developed by the Center for Systems Science and Engineering. And you can see this is a huge amount of data that they have collated and put in one dashboard in a way that we could track the development of cases all over the world. So what's big data? I want to share the definition by the Health Directorate of the European Union, where big data is defined as high volume data with high diversity in terms of biological, clinical, environmental, and lifestyle information collected from large numbers of individuals to large cohorts in relation to their health and wellness status at one or several time points. So when we talk about big data, we commonly quote the 5 V's of big data: volume, variety, velocity, veracity, which means the data is clean, and of course, the value of the data itself. These are some key enablers for big data. Firstly, the platforms to capture all possible relevant data. And the COVID-19 pandemic has given us this big opportunity for us to sort of obtain this valuable data in a large-scale manner. Number 2 is the environment and culture for data sharing. It is so important for us, not only within Malaysia to share this data, but also at the global data or at the global level. Thirdly is gaining public trust for us to use their personal data. As we know, a lot of the health data are related to personal data, personal identifiers, and so on. So getting the public to consent for use is very important. Finally, the interoperable systems across hospitals, states, and agencies. If we use the hospital information systems, including electronic medical records, we must make sure these systems are interoperable for data migration and data sharing. And all this will sort of be collected, or rather will enable the formation of huge and vast data lakes and data warehouses for analysts and researchers to access and use. So in terms of the use of big data for public health, we can see the benefit here. These are not sort of exclusive. The use of big data will certainly lead to earlier diagnosis, better quality treatment, and of course, less adverse reaction. It widens the possibility of prevention of diseases through also good prediction, as well as changes of lifestyle, and so on. Prediction of outcomes and also cost benefit and cost effectiveness analysis, and also improvement of pharmacovigilance and patient safety. So this is an experience by China. They published this in 2020. If you look at the conceptual structure chart of prevention and control of COVID-19 with big data technology, if you start from the bottom, that's a collection layer where all the possible sources of data are mobilized, including telecommunication operators, the internet, the electronic medical record, travel data, government information system, smart and wearable devices, questionnaires, and so on. The second layer is the data layer. This is where data is stored in large databases, data lakes, and data warehouse, and with a clear data governance policy. And usually it's a single or a central governance that is practiced. The third layer is the analytical layer, where the application of big data analytics happens in terms of descriptive analytics, diagnostic analytics, predictive analytics, and prescriptive analytics. And last but not least is application. And this is where you see data-driven decisions being made, epidemic surveillance and early warning, drug screening, drug policies, treatment policies, as well as policies on control of movement as well as lockdown. So if we take a single individual that is tested positive during COVID-19, these are the opportunities to collect large data sets when you build up this database on so many different cases. You see a patient or a person going for COVID-19 testing, there you go, we have the demographic data. When we do the RT-PCR testing, there's an opportunity not only to get the positive or negative data, but also to do genome sequencing. When we sort of trace this particular positive patient in terms of the movements and also contacts, we get data on contacts and also travel data. And when the patient is examined and then admitted and goes to treatment, we have the data on our electronic medical record, imaging data, as well as laboratory data. And patient might be offered a clinical trial to test a new drug, and we have the clinical trial data. So all in all, we have possibility of getting patient DNA data, the viral genome data, clinical data, imaging data, and response data. And the access to these large data sets to various researchers for analysis is critical. So if we look at this example of how big data analytics identified loss of smell and taste as the clearest indicators of early infection. So this is published in Nature Medicine in 2020. If you look at it, this was an effort by two large universities where their researchers developed a smartphone-based apps, one at the group by Mass General Hospital, and working together with the King's College of London. And they had more than 2.6 million participants that used this app to report their symptoms, and 18,000 plus of them had COVID-19 testing, and more than 7,000 were positive. And by big data analytics, they noted that loss of smell and taste were higher in those who were positive of COVID-19, giving an odds ratio of 6.74. And this is used by many as the first indication of infection for COVID-19. So this is the COVID-19 vaccine efficacy data, something that Malaysia can do as we have embarked on our vaccination program. It's an opportunity for Malaysia to show the vaccine efficacy data, more so when we have several different vaccines that's going to be used. This table is taken from several publications in Lancet and New England Journal of Medicine, where it showed in countries like Israel, UK, and US, where they have started ahead in terms of the vaccination program. It showed how the vaccines have decreased the number of infections in both for the general public as well as for the healthcare workers. And also it affects in terms of the severity of hospitalization and the number of deaths, where the vaccine is showing the effect or the efficacy of lowering this number of hospitalization as well as mortality. There are also two big initiatives of big data and artificial intelligence that I believe which we could see as making a big impact in terms of the management of COVID-19. One is the artificial intelligence application to imaging, where large numbers of chest X-rays were analyzed by AI teams, and they have come up with algorithms that could improve the prediction of COVID-19 changes even better than some radiologists. That's what this AI team claims. And of course, this needs to be further fine-tuned, but these are really promising data. The second part is the repurposing of drugs. And this is where big data and the use of artificial intelligence have discovered new drugs, or rather existing drugs, that could be useful to be repurposed for the treatment of COVID-19 infection. If you look at this, approach, how leveraging data libraries to repurpose new drugs requires the interaction or the alliance of many groups. You look at the pharmaceutical companies coming in, academics and researchers doing drug discovery and drug research, and of course the existence of libraries of compounds and established drugs, and publicly available data or published data on targets on the virus. From this effort, there were some candidate drugs that has been repurposed for COVID-19, and this includes hydroxychloroquine, azithromycin, chemostat, and remdesivir. So I would want to highlight this part on the big data in terms of issues and challenges. So there are opportunities for us to improve data collection and access to electronic questionnaires, social media platforms, improve data usage through smarter integration of various data sets, and to allow people or researchers or experts who are really skillful at handling AI and doing machine learning to access and analyze this data. Data innovation includes strengthening data collaboration and integrating multidisciplinary knowledge and analytical methods. And last but not least is improving data privacy. As we are dealing with a lot of personal data from the public, we need to enhance the data privacy framework, and also the need to digitize the patient's identity. But what we see happening on the ground is quite heartening and promising. There is an increased spirit of collaboration. There is a belief on the need to prepare for future pandemics. Data is there, huge data out there in the Malaysian context, but perhaps not integrated and digital enough. We can improve on this. The public wants transparency and science-based decisions or evidence-based decisions. There are certainly gaps in our scientific preparedness, but many ministries, the relevant ministries, are handling this. And our hospitals are not designed for pandemics, but we have done really well in terms of the handling the pandemic over the past year or so. I'd like to move to precision medicine, which is very much related to big data analytics. So the definition of precision medicine, to put it simply, is that it uses individual unique features, including genes, environments, lifestyle, in tailoring treatment. This would promise better prediction of treatment, prognostication, outcomes, and less adverse reaction. In essence, it is actually an approach to give the right treatment for the right patient at the right time. So there is a huge interaction in terms of big data and precision medicine. And if you look at the applications of big data in precision medicine, you can cluster them into three: basic research, clinical research, and clinical practice. In basic research, this is where we discover new molecular targets for new therapies and discover biomarkers to identify those who are going to respond to your treatment or who are at risk of adverse events or also at risk of diseases. Clinical research, there are a lot of clinical testing of targeted therapies happening now, and also clinical testing of novel diagnostics using genetic panels or predictive tests for cancers and other non-communicable diseases. So in clinical practice, big data implication in precision medicine includes providing better diagnosis and better classification of diseases, and also using targeted therapies. And last but not least, more effective preventive care with accurate prediction. So if you look at COVID-19, this is a disease of heterogeneity, susceptibility, and also outcome. Big data analysis and also publications involving large number of cases have shown hospitalization and mortality are higher in the older age groups and in males. This is also higher in American Indians, Alaska Natives, Blacks, and Hispanics compared to the whites. This is an observation in the United States. Case fatality rates that differ between countries. White patients who benefit more from remdesivir than the other ethnic groups. Certain COVID-19 variants that are emerging that are causing higher death rates. And the presence of comorbid factors, especially diabetes and hypertension, that influence the outcome of the disease. Yes, so for precision medicine and COVID-19, there are a lot of opportunities for us to embark on research and also important studies that could sort of contribute to the management of COVID-19. First, the ethnic and genetic differences in presentation and severity. And Malaysia is rich in terms of the ethnic diversity. In addition to the three large ethnic groups, Malays, Chinese, and Indians, we have the other smaller indigenous groups and so on. There's also massive variation in spread and case fatalities, and Malaysia can boast of a much lower case fatality rate. This is something that this is a valuable opportunity for us to find out why. The host and social determinants of response to treatments. And last but not least, the viral strains and how it affects response to treatment, and also the current vaccines. So let's see why men are worse off than women. Many of us probably have read this in many publications. So in males, it's thought there is a higher inflammatory response happening if you have COVID-19 infection, and this is the one causing or contributing to the damage, to the tissue damage. In women, they have the protective effect of the estrogen signaling. Males have higher ACE2 levels, and we know the virus goes through the cells through the ACE2 receptors. There's a higher toll-like receptor 7 expression in females, which leads to the innate immune response and the antiviral response. And females are known to have higher B cell counts and greater antibody response to vaccination, and there is a related effect of the testosterone as well. So there are also other key observations in terms of the individual variations and also the variations or differences across nations and ethnic groups. For example, 71% of males admitted had the male baldness pattern, and of course this related to the androgenetic effect. East Asians have higher ACE2 expression in tissues. Countries with BCG vaccination programs have less cases and lower case fatality rates, again related to the immune response for those who have had BCG vaccination. The UK Biobank did 2 large studies, and 2 of these are recorded here. The actually DQA1509 variant, which is enriched in those positive cases of COVID. And they also identified a variant called RS286914 with an odds ratio of 1.52 in relation to those who are positive. And there was also a subset of patients with T cytopenia that responded to interleukin-7 treatment. There you are. There are a lot of opportunities to look at our own cohort of patients to discover the cause of the variations and perhaps to contribute to better management in terms of the precision medicine approach in dealing with COVID-19. These are also more opportunities for research in precision medicine in COVID-19. The look at previous drug use. Maybe we could find drugs that have been used by patients in the past year that are either give them a higher risk or protective of them to get the infection. A systems biology approach that looks at viral and host targets that may be modulated during infection, clinical trials for repurposable drugs, and in Malaysia case, whether they are herbal or natural products that are available that can modify the cause of disease. Last but not least, we need to form strong alliance with industries, collaboration with pharma companies, basic scientists, and also data scientists. More opportunities for research in terms of determining the outcome and mortality of COVID-19. As I've mentioned before, we need to strengthen and widen our data platforms, collect data and biospecimens, and this is where we could analyze in terms of the genotype, cytokines level, H2 expression, actually typing, do the viral genome sequencing or viral genome surveillance, measuring immune response even as we embark on the vaccination to see the post-immunization immune response. Data analytics then would allow us to understand the individual variability and ethnic differences. And finally, we can apply this data for risk profiling, precision medicine, policy decisions, vaccination, and targeted therapies. My last part of the talk looks at the COVID-19 viral genome itself. Since the pandemic began, we can see the changes in terms of the viral genotype itself. This is phylogeny of COVID-19, which is shown our presence in the GIS8 website. And if you look at the viral genome sequences submitted to GIS8 over the past few months, you can see the countries leading in this effort. And Malaysia so far have submitted about 400 over viral genome sequence to GIS8. And there is an important need to do genome surveillance because we know the application is in terms of looking at response to treatment and also monitoring the changes and also the transmission of the virus. We have seen the emergence of these variants, the B117 from UK, which causes increased transmission and severity. The B1351 from South Africa, which has caused increased transmission and decreased neutralization by convalescent sera, and the P1 from Brazil that also has shown moderate impact of neutralization by monoclonal antibodies. And what worries us recently is the E484K mutation that has caused the loss of neutralization neutralizing epitopes in the spike proteins, and this may worry us about the efficacy of vaccines. So this is an opportunity for genome surveillance for Malaysia. So I'd like to share this program, although this is in the proposal stage, but this is what we plan in the immediate coming weeks to establish Malaysia's 10,000 COVID-19 Genomes Program, a collaboration between three big ministries, the Ministry of Science, the Ministry of Higher Education, and the Ministry of Health. 7 labs in 6 institutions will participate in this genome surveillance program, and we hope we could contribute in terms of monitoring the virus in terms of its mutational changes and also tracking the transmission, as well as contributing this data to GIS-8, to the International Genome Consortium database. And of course, there are opportunities for new cohorts and biobanking for COVID-19 related biospecimens. We could have a COVID-19 patients cohort, a COVID-19 vaccinist cohort, and getting diverse streams of information, including genomics, social determinants of disease and risk factors, environmental exposures, and electronic medical record, and also data from wearable devices. So in conclusion, there are many opportunities for research using big data analytics. We could possibly use the data or information gathered to apply the approach of precision medicine that could potentially improve the outcome. We need certainly to improve on our data collection and organization. There are opportunities for new cohorts with big data and biospecimens. There's a need to bring together more experts across ministries and disciplines. We need to build capacity in big data analytics and AI relevant to healthcare, create an environment conducive for data sharing, and last but not least, sustainable funding to ensure competitiveness and also to ensure all our efforts for these big initiatives during the COVID-19 pandemic will become successful. I thank you very much for your attention.